We have two speakers today. The first is Jack Savino. He spent the last month with us, one of our sub-Is. He's done a fantastic job. Just gonna pull up his IO here. All right. So Jack Savino is a fourth-year visiting student from Wake Forest School of Medicine. He grew up in Virginia Beach, Virginia, and attended the University of Virginia, where he majored in biology. Between UVA Medical School, he spent a year working as a medical assistant in dermatology practice. After spending his pre-clinical years in Winston-Salem, he had the opportunity to complete his third and fourth years at Carolinas Medical Center in Charlotte, where he currently resides. He is very grateful. Well, I'm sure he'll tell us about his experience here, and he'll give us a nice talk on immediate versus delayed penile prosthesis implantation in patients with ischemic priapism.
Thank you for that introduction. Before I get started, I just wanted to say thank you to everybody. It's been an amazing month. Everybody's been super welcoming, and let's get started. So I'm going to be presenting on immediate versus delayed post-priapism penile prosthesis implantation. So priapism, what is it? Priapism is a persistent penile erection that is unrelated to or persists long after cessation of sexual activity and is classified into two main categories. The first category, which accounts for about 95% of all priapisms, is an acute ischemic or veno-occlusive low-flow priapism. It's a persistent erection characterized by no cavernous blood flow and abnormal blood gases. The cavernosa are tender to palpation, and patients will always report pain. There is a stuttering subtype of this, which is a remitting and relapsing ischemic priapism where patients achieve partial detumescence. So a non-ischemic priapism is arterial or high flow. These are much rarer, and it is a persistent erection that lasts hours to weeks and is frequently recurrent. The underlying physiology is not fully understood, but seems to be related to unregulated control of arterial inflow and cavernous smooth muscle tone, and it's non-tender and never painful. Those are important differentiators between the two. The picture on the bottom left there is just a Doppler flow of an ischemic priapism, a low flow, and then on the right there is just an example of a high flow ultrasound. So the underlying pathophysiology is mainly from dysfunction of the smooth muscle due to prolonged ischemia. So when you're not getting blood flow in, your cells are still using oxygen, they're still creating CO2, it's lowering the pH, creating acidotic tissue damage, which is painful and leads to fibrosis scarring. The most common etiologies I've listed here: sickle cell disease is probably the most common, followed by trazodone, recreational drugs, idiopathic spinal cord injury, and then trauma. Trauma is a little interesting because depending on the trauma, you can have hematoma formation that blocks venous outflow, or you can have an arterial injury within the penis that is actually a high flow priapism. So the initial workup and treatment, it's mainly just a history and physical that'll give you the diagnosis almost all the time. Pain is the big differentiator, like I said before. Rigidity is a big one. Rigidity, usually patients with an ischemic priapism, their penis is more rigid than someone with a non-ischemic high flow priapism. And then medical history, a lot of times patients that come into the emergency department, this isn't the first time this has happened to them. So just getting a really good detailed medical history, and then obviously if they've had any prior trauma. So what do you want to do when they come to the emergency department? Well, first, I probably want to get a CBC, look for any signs of anemia or sickle cell. Doppler flow is actually only indicated in high flow priapism, so you don't really need to order that. If you can, it would be good to get a corporal blood gas. However, sometimes if the blood, if they've been, in a priapism for a long time, a lot of the blood may be clotted, and it may be actually quite difficult to get a corporal blood gas. But nonetheless, treatment, it's aimed at achieving 4 goals. First is pain control. You obviously want to make the patient comfortable. You want to resolve the acute event, and this is done through aspiration and irrigation of the corpora with phenylephrine. It's a sympathomimetic. And this is done, you dilute it with saline, and it's done in 100 to 500 microgram aliquots every 3 to 5 minutes until you reach a dose of 1,000 micrograms. You want to preserve the erectile function and prevent recurrence. And then this picture down here shows typical blood gas values for an ischemic priapism. So not all patients that come in with a priapism are going to develop severe erectile dysfunction. Here are some of the risk factors for patients who are at a higher risk of developing severe priapism following resolution of the event. So time erect at presentation was the most strongly predictive factor for these patients, followed by degree of fibrosis, sickle cell disease, and then a prior distal shunt surgery as well. So although corporal aspiration irrigation with sympathomimetic administration is 80% effective, sometimes it doesn't get you to where you need, and you need to proceed with a procedure. So there are 3 types of shunts. Typically, only 2 types of these shunts are done today, but just for completeness sake, I'll go through all 3 of them. So the first type of shunts are distal shunts, and there are 2 types of distal shunts. There's percutaneous distal shunts and an open distal shunt. Percutaneous distal shunts, you have your T shunt, your Eberhard shunt, and your Winter shunt. And that's shown in the picture on the bottom right there. And then you have a open distal shunt, which is the Algarab, or a cavernosal spongiosal shunt, where you make 2 5mm by 5mm incisions in the glans penis, basically carving out 2 cones and expressing the blood out that way. And then there's also this new practice, well, not new, but it's gaining more traction, where you do this corporal snake maneuver after an Algarab distal shunt. You will insert a 7/8 Hagar dilator into the corpora following a transglandular incision, like I described before. And then this can be done initially or following failure of your original distal shunt. So proximal shunts, these are the second most common type of shunts. They allow for blood flow from the proximal corpora to the spongiosum. There's Quackles, it's a perineal approach, and there's Sacker, it's a penoscrotal approach. That approach, you make the same incision as if you were placing a IPP. And there was a study that I found, Mori et al. Published a study in 2020 where 25 patients underwent penoscrotal decompression. 15 actually had return to sexual function, 9 spontaneously, 6 with the use of PDE5 inhibitors, and their mean time to presentation was 71 hours, which I found was pretty remarkable, that many of them were able to maintain their sexual function without having a penile prosthesis implantation. Venous shunts. So these are the more historical in nature, not done today, but just for completeness sakes, you can anastomose to either the saphenous vein or the dorsal vein of the penis. And all 3 types of these shunts will have high rates of postoperative erectile dysfunction. Distal shunts, proximal shunts tend to have higher rates of postop erectile dysfunction than distal shunts. But if your patients did get a shunt, should you implant them now? The AUA, they say that clinicians may consider replacement of a penile prosthesis in a patient with untreated acute ischemic priapism greater than 36 hours, or in those who are refractory to shunting with or without tunneling. In a patient with acute ischemic priapism who is being considered for placement of a penile prosthesis, clinicians should discuss the risk and benefits of early versus delayed placement. So that's what we're going to do here. So is one better than the other? This is a meta-analysis published in March of this year, which I thought was a really good study that took a great look at 9 different studies. There's 278 total patients. 32 of them underwent revision surgery. 90 previously had a shunting surgery. 214 received malleable implants. 61 received an inflatable prosthesis. There was a wide range of patient follow-up ranging from 11 to 43 months, with 7 out of the 9 studies reporting a follow-up of 1 to 2 years. So the good stuff. So for anyone that isn't brushed up on their statistics, this is a forest plot. A forest plot is used in meta-analyses where you are looking at multiple studies that assess the same variable. The black line in the middle, that's an odds ratio of 1. So anything to the right of that is greater than 1, to the left of that is less than 1. The black diamond that you see there, that is the mean odds ratio for all of the studies. And if any part of that crosses the line in the middle, then it's not statistically significant. So as we see here, fibrosis, there's clearly a trend or statistically significant result that there's more fibrosis in patients that received a penile prosthesis later. And that was defined as 1 month after the onset of priapism. So patient satisfaction, here we see again that patients who received prosthesis earlier reported more satisfaction than patients who received it after a month. Total complications, there were more complications in the late group than the early group. And then the authors didn't find any statistically significant differences in postoperative erosion, postoperative infections, and penile injury. Penile injury was defined as urethral injury or corporal perforation, although there is a clear trend showing increase in erosion of penile injury in the late insertion cohort. So just looking closer, one of the studies included in this meta-analysis was Salman et al. He retrospectively reviewed records of 42 male patients between 2019 and 2022 with refractory ischemic priapism. 23 had insertion of a malleable prosthesis, and that was defined as 1 week since onset of priapism, and 19 had delayed insertion of a malleable prosthesis, which was defined as 3 months or later than the onset of priapism. So here it shows how long the procedure took, the implant length, and the girth of the implant. And as you can see, that the operative time was pretty significantly longer in the delayed group than in the early group. The implant length and the girth of the implant were also larger in the early insertion group than the delayed insertion group, suggesting that there has been some loss of penile length, significant fibrosis, making the surgery much more difficult. Here is just some more complications regarding the early versus delayed insertion group. As you can see, early insertion, they're going to have higher rates of penile edema just because the state they're in. But corporal perforation and urethral injury shown here were higher in the delayed insertion. So malleable versus inflatable, which one do you do? Well, a malleable prosthesis, it's more cost effective. It's a faster operation. It's easier to implant and explant. It has a less natural appearance and it's constantly firm. An inflatable prosthesis, this gives you good natural function and appearance. Patients can achieve complete detumescence. Cons, more expensive, more technically challenging operation, and there's more potential for mechanical failure. Either option is good, and the choice really depends on the surgeon's comfort level. If patients do opt for a later insertion, they want to wait till after they recover from this, it's recommended that they use a vacuum 3 to 4 times a week to prevent penile shortening and just get good blood flow there to facilitate healing. So in summary, penile prosthesis implantation is a good option for patients with a recent or current ischemic priapism due to the high likelihood of developing severe erectile dysfunction. Early implantation helps prevent penile shortening from fibrosis, is associated with fewer complications, and has higher rates of patient satisfaction. Both early implantation of malleable and inflatable devices are associated with better outcomes.
All right, I'll be introducing our next speaker, our own Dr. Joshua Sterling, who's an assistant professor of urology specializing in trauma and genitourinary reconstruction. He completed his GERS fellowship in reconstructive urology and transgender care at SUNY Upstate. He earned his medical degree from New York Medical College and completed his urologic residency at Robert Wood Johnson in the great state of New Jersey. Dr. Sterling's clinical areas of interest are urethral and ureteral strictures, genitourinary fistula, urinary complications of radiation, and gender affirming surgery. His research interests focus on stricture formation, tissue regeneration, and the effect of sex and gender on healthcare outcomes. He's the author of over 50 peer-reviewed manuscripts and book chapters, and is a co-author of the American Urologic Association core curriculum on gender affirming surgery. and he'll be giving his talk. If there are no new ideas, what is surgical intervention? Dr. Stelling.
So everyone can ignore the program goals. I had a different talk planned and then Jeffrey stepped on it a little bit, but when one door closes, another window of opportunity opens. So it kind of gave me the option and opportunity to talk about surgical innovation. So for this talk, I don't have any disclosures. First, I'm going to explain why I say that there are no new ideas. Then we're going to talk about ideal recommendations, and ideal is a specific timeline of surgical innovation. Highlight an example of a problem with a good solution, talking about fossa navicularis strictures, a solution without a problem, looking at the new push for Optimum for BPH. And then an open question, bringing it back to Jeff's talk last week about what do we do for bladder neck contractures or vesicourethral anastomotic strictures. So as I was preparing for the talk, I came across this quote from a 19th century essayist and he says, 9 out of 10 of what we call new ideas are simply old mistakes. So little audience participation. What do we think the first documented reconstructive urologic procedure was? What was the year? Max, shout out something. Okay, 1000 AD. Ellen?
1400.
All right, 600 BCE. What about the first documented use of an adjunct treatment to prevent scar reformation? So kind of coming on the new thing is Optimum and using the balloon and delivering paclitaxel to prevent. What's the first time that in the documented history someone reported trying this? 1500. What about the first internal urethrotomy device that was actually used in a human patient? All right, 1817, I'm getting closer. First partial nephrectomy documented in the literature, patient survived. 1887. And then the first successful use of buccal mucosa in the urethra was 1890. So these things that we think of as relatively new advances in surgery are actually pretty old. And again, these are the first that we can find reported documented in the history. It doesn't mean it was the first time it was done, and who knows how much has been lost to history. So India, 600 BC, this is the person who is dubbed the father of surgery. Writes in his treatise that for a patient who has trouble urinating, you can put a tube in the urethra, open on both ends. You lubricate it with clarified butter, it's gently inserted into the urethra. And he also understood that you needed to increase the diameter slowly over time. So every third day, it would be a larger tube. Ancient Egypt, this is about 300 BCE. This is a temple of healing in ancient Egypt. And while my hieroglyphics aren't great, the guide told me that you can see here, this is a basically prescription for how to help patients who couldn't urinate well. So I guess the small frequent dots where they were dribbling, they do a procedure. So they take a reed, again, stretching out and dilating the urethra. There was also a prescription for a tincture of healing, which involved some parts of the crocodile, and the patient would urinate better afterwards. So urethral dilation with antifibrolytics in the 1500s. After dilating, they would put some caustic substance at the tip of whatever was dilating, and then wash out the urethra with vinegar afterwards to stop the reaction. This is also the first documented use of trying to use something to physically remove that scar tissue. So Ambrose Paré, a French physician, had a silver instrument, which was sharp at the end, which he would try to remove the scar tissue. First internal urethrotomy devices, the end of the 1700s, first in France. First, it was just a blade that could be advanced to cut the scar tissue. Then they decided they should probably have something around the blade so that would protect the rest of the urethra from it. So the first internal urethrotomy was in 1817. The idea that you, again, shouldn't just blindly place it, you place a guide. This was first described in 1850. Endoscopy, the 1870s in Austria and Germany. So first you had the urethroscopy with light reflection and then the first DVIU. These wouldn't gain real popularity until Thomas Edison comes along and invents the incandescent light bulb, and then Harold Hopkins comes along and invents fiber optic cables and zoom lenses. But still, the idea was there. And then finally, flaps and grafts have progressed and been described throughout the 1900s. Basically, since we started writing about medical procedures, we've really understood that for most urologic complications, We wanted to use a native orifice. We want to remove the obstructing tissue. We want to do something to prevent recurrence, and then ideally discharge the patient, get the patient back to their normal day-to-day life without having to come back. And kind of every new iteration that we've had since then is still in service of these main goals. As I was preparing for this talk, I came across this publication from a couple of years ago in the Journal of American Surgery, talking about the role of the academic surgeon in practice. And while I kind of disagree that a non-academic surgeon is only focused on patient care, I did like that their highlight on surgical innovation. Specifically, what surgical innovation is supposed to do is supposed to develop a cost-effective solution for a daily surgical problem. And it's really that highlight of what is the problem. Your aim at progressing the field should focus on a problem as opposed to a device or a typical surgery. So it brings us to the question, what is the problem? Does anyone know what this is from? Yeah, so this is the original King Kong, this 1933 production of King Kong. And this is King Kong attacking the village. And I want you to think about this image as I go through the rest of the study and think about what is the problem and how you would address that problem. So this is a graph of an adoption of laparoscopic surgery. So the first laparoscopic procedure was a laparoscopic cholecystectomy done in 1985. As you can see from the red circles, that's the adoption of cholecystectomy to laparoscopic procedures. Some of the other ones that are interesting for us is the gray square, which is nephrectomy for cancer, and the green triangle, which is nephrectomy for benign disease. Within 5 years of the first reported laparoscopic cholecystectomy, almost all choles that could be done laparoscopically were 70%. And it can contrast that to nephrectomies for cancer by 13 years later, so almost the year 2000, still less than 10% were done. I generally consider urology to be a pretty innovative and forward-thinking field. And so the question is, how come laparoscopy didn't take off so well for urologic procedures, but it did for cholecystectomies? And if you just think about the problem with a cholecystectomy, so if anyone has seen anyone with an open chole scar, is a giant incision, basically half of their abdomen, to get to a single organ that has a single vein, artery, and one problem area that you're looking for. So general surgeons always talk about the critical view of safety. You've identified the cystic artery, you've identified the cystic duct, and you make sure that you're away from the common bile duct. Pretty simple problem, so you can go in laparoscopically, a couple of clips, and take it out. As opposed to these other organ processes, why it wasn't so rapidly adopted for colorectal surgery or urology, where you might have more problems than that one simple thing. We had recently Dr. Menon talk about his experience with robotic surgeries and why was that early adoption and rapid expansion of robotic surgery for prostatectomy. Again, thinking about what the problem was. For continence, it was a problem of suturing down in a very dark hole, and the robot changes that. You can see from a rapid adoption from both how quickly it accelerates as people realize what this new technology, what this new surgical technique can offer, as well as how rapidly it starts to replace open surgery. And this is after several very prominent figures in the field had said that there was no role for laparoscopic surgery for the treatment of prostate cancer, because the advantages that laparoscopic surgery added to the surgeon's armamentarium didn't really address the problems encountered during a retropubic or a perineal prostatectomy. So it's not just having a good technique, it's not just having a good device. That device needs to address the biggest problem that the surgeon has in delivering excellent care to the patients. So this comes to the ideal process for surgical innovation. So there are 4 stages, kind of 5, of surgical innovation. Stage 1, the idea. So you have your problem and you're doing your proof of concept. What can we do to try to address this problem? This is the innovators that are doing it. Your output is describing the surgery. You want pretty selective patients for this. And then you're going to move into phase 2, which is the development, D. So again, you're trying to refine that technique. Slowly more people are doing the procedure. The Procedures development isn't still there. You're still tweaking steps. You might be developing and coming out with new tools to help you with that. 2B is exploration. You've kind of formalized what the steps of the procedure are, and now you're seeing how many patients, what kind of disease etiologies can you apply to this surgical innovation. This is where you're doing measurements. You're now comparing your new technique to what is the gold standard. This is where you're starting to have larger, not just case series, but actually retrospective database research, as well as randomized control trials. 3 is the assessment. Once you get into 3, the procedure is basically pretty well established. And now you're assessing what are the outcomes of it, what are the benefits. And then finally, 4, long-term studies. And here you are assessing how this product, how this surgical innovation has changed and moved the field forward. So again, just so that you can see it in an easier thing. So in stage 0 or 1, so 0 would be you're doing the procedure on non-humans. So whether that's cadaver studies or animal studies. Stage 1, you finally bring it into practice in the operating room. So it's the first use of a new procedure in a patient, and it needs to be prompted by a need for a solution to a clinical problem. In the development stage, you're trying to work out the technical aspects of it, making sure that you have improved and optimized whatever the equipment is. And the details aren't still fully being worked out. So you're figuring this out. And in this stage, it's really important to be honest about your outcomes. The failures are probably more important than the successes, because that's what you can learn from. That's where you learn, where you still need to iterate, you still need to improve on that technique. So in the exploration phase, again, the technical details have been worked out, but now you're trying to explore broader indications for it. You might have started with a very specific and selective patient set, and now you're broadening that out. In the assessment stage, this is becoming the standard of care. This is where you find that patients start to ask for the procedure. And finally, long-term, you're looking back, you're seeing, how has this changed? How has this changed not just the surgery, but also all aspects of medical care? How has it changed our pre and post-operative care? And how has it changed our training? So going back, and they've applied this to laparoscopic cholecystectomy. So stage 1, the innovation. First case of a laparoscopic chole in Germany in 1985. Reported in the literature, it says, couldn't translate the whole case report, but basically the top line item is, I was able to do the surgery without any of the morbidity and post-operative complications associated with an open cholecystectomy. Stage 2, suddenly it's not just in Germany, now several patients are being treated both in the United States and in France. And what I found was interesting is that there was an early mortality in Germany, and they stopped doing the procedure in Germany. And so the next wave of this is not led by the German surgeons, but instead by French and American surgeons. So kind of these early complications can play a large role in whether a technique or a surgical innovation proliferates or not. Realize that some of the laparoscopic instruments that had been designed were designed for gynecologic procedures, didn't really work for what they were doing. So on the industry side, they're starting to rework those to address the needs for laparoscopic surgery. There was a laser that was being developed, similar to what we do for stone disease, to go in and break up gallstones. That is completely now discarded. Nobody is investigating that anymore. And then finally, something kind of led to this rapid proliferation is an American news network found out about this and broadcasts a live surgery to a wide television audience, kind of introducing it to the public. Stage 2B, we're kind of realizing how we can do this. And this is where you start to have hospitals and review boards develop certain criteria and accreditation to be able to do the surgery. So it's not just kind of the Wild West or frontier. Now there should be some standards of training about who can perform this new procedure. Stage 3, now most academic departments are moving away from open cholecystectomies. They're only doing laparoscopic. You have the first large case series. Suddenly there are now training courses, which are sponsored by industries. Basically within 2 to 3 years of the first reported ever minimally invasive surgery, this has become the standard for the industry for any sort of cholecystitis. And then looking back on it, how has it changed? So this is where you start to see publications about learning curve. How many procedures does it take to become proficient? What happens in that learning curve? How can we speed up the learning curve for the next generation of surgeons? You've had the first randomized controlled trial published in 1992. In addition to the laser, I didn't know that they were also trying to use Eswol for gallstones. That is now an obsolete option for it. And what was really interesting is that several years after the start of laparoscopic cholecystectomies, I looked at, Canadian surgeon looked, and in Ontario, the number of cholecystectomies had gone up, although the recognized indications had not. So now we're doing more surgeries for this because we can do it easier. So again, how has this innovation changed the field? Taking all that as we're looking back, when you're thinking about what is a good surgical innovation, it should always start with the problem. So you want to solve a problem. Ideally, it should lower the barrier for entry. And what do I mean by that? Is if you have a surgery that can solve any disease for any patient, but only one person can do it, it's not a very good surgery. It needs to be teachable, it needs to be scalable so that it can help the most number of patients. It should increase the number of eligible patients. So you shouldn't only be doing this on the very sick or patients that are kind of desperate for some sort of improvement. And then it should work for multiple etiologies. A surgical innovation that only works in a select number of patients for a select etiology is an incomplete innovation. We need to figure out why doesn't it work in those other areas and try to see if we can solve that. So now some examples. So this is the problem with an obvious solution. So false navicular strictures are pretty difficult to do it. Extending the top, creating a megamegatus, or trying to do something to address that stricture. And these are diagrams taken from the largest case series on this that Dr. McInnish published. So what you do is on the ventral side of the penis, you make an incision, expose the urethra. You have your ventral urethrotomy. You are cutting out the scar tissue, depending on if it is completely obliterated or not. You're elevating a flap of the penile skin and creating an onlay, or completely tubularizing it and advancing it through the glands, doing glandsplasty. And then here's the final result. So you have your stitches in the glands for the glandsplasty, you have your skin incision, and then underneath it you have the incision for where you did your urethrotomy. This kind of violates one of the core tenets of reconstructive surgery, is trying to avoid overlying suture lines. The other problem with this surgery is that there's not a lot of tissue there. So you can't really bring in other tissue to try to cover and bury this suture line. So when you're doing a hypospadias with Dr. Hitteman and Dr. Arlen, you have like 3 or 4 additional suture lines over the initial anastomosis. The more layers on top of something, the less likely there is to be a fistula. So I can tell you that this is a surgery that I have never done. It was a surgery that I was told I should never attempt because in my hands, it's not going to work. So the problem is that this is a difficult surgery that not a lot of people do. The biggest case series on it looked at 19 patients over almost 10 years. It leads to overlapping suture lines, which eventually lead to fistula repair. It can also have problems of gland necrosis and breakdown. So what is the obvious solution for this? Avoid the skin incision. So comes with the advent of a transurethral approach for it. So from the urethra, we can excise the scar. This is the ventral approach, which was popularized by my fellowship mentor, Dr. Nikolowski. You can also do it dorsally. You deliver the graft transurethral, tying your sutures on the outside. You're avoiding any sort of skin incision. You are minimizing the chance of any fistula formation. You're going back to our initial history and lessons. We're using a native orifice, we're excising the tissue, we're putting a graft in there to prevent any sort of scar reformation, and then we're discharging the patient. So that's the ventral repair. There's also a dorsal repair. So kind of does this check the boxes of good surgical innovation? So it addresses the problem. It definitely lowers the barrier to entry. And I can say that because I can put my name up there and have similar results with surgeons that are significantly better than I am. So Dr. McInnish, in his 9 years, found 19 patients. They had a 94% success rate. Dr. Nikolowski looked back over 7 years, he had 44 patients. Dr. Bani, who does a dorsal approach instead of a ventral approach over 5 years, 16 patients, and then the year and a half that I've been here, I've had 7 patients in an 86% rate. So we are increasing the number of patients that can do this. We are lowering the barrier for entry in terms of the number of surgeons that can do this procedure, and we are addressing the problem and the complication. This also works for multiple etiologies. So it doesn't matter if the patient has had multiple surgeries in the past, has had lichen sclerosis in the past, it is applicable and appropriate for all of those etiologies. All right, so now a solution without a problem. So here's what it looks like when you start the end of the story with a device. So for those who don't know, and again, this is not a critique of the device itself, but the process that they got to start advertising it to the public. So Laborie invented the Optilume balloon, which was first used for urethral strictures. The idea is you balloon dilate a stricture and then you deliver paclitaxel to prevent microtubular polymerization, prevent any sort of fibrosis recurrence. It works well in the urethra for small urethral strictures. And they are now pushing it for a procedure and a treatment for BPH. So you put a big balloon in, you dilate the prostate, forcefully rip open the anterior commissure, and you put another balloon in, the drug release for the balloon to prevent any sort of scar reformation, and they claim it has durability. I would question their premise that there was a problem that they were solving. And I would go back to the initial studies and kind of read their own words back to them. So they say, historically, TURP has been regarded as the benchmark, but it has, and so they're saying that this is better than that. They're saying that TURP is invasive, necessitates inpatient hospitalization, and may be unsuitable for patients who can't tolerate anesthesia. For that, I would ask the residents to think about how many TURP patients have long hospitalizations, and for a patient who necessarily can't do anesthesia, there are other options like spinal. They then say that robotic, so talking about aquablation and TURP, required general anesthesia in an operating room. All of the patients that they did their studies on for this also required general anesthesia in an operating room, and may require invasive bleeding management, such as a transfusion. Again, think about the patients that you've taken care of after a TURP and how many of them have needed a transfusion. In my training, I honestly can't think of anyone that has. Then they're talking about how there are other complications associated with TURP, including retrograde ejaculation and erectile dysfunction. So you go to the primary citation of this for the erectile dysfunction. It's a 1995 New England Journal of Medicine study from the VA, looking at the difference in ED in patients who had a TURP versus watchful waiting. The results, after 3 years in the TURP group, another 19% of patients reported ED. And the patients who had nothing, 21%. So not really a problem there. And I would say that Dr. Kaplan is aware of this data. And then finally, the goal of this technology is to deliver immediate symptomatic relief via balloon dilation and achieve durable results, which is an admirable goal, but not really a goal addressing a problem. If you look at the first study from the laparoscopic Foley, going back to that, it said I was able to do this surgery without any of the complications associated with open surgery. If you look at the first publications about robotic prostatectomy, it says right there in the introduction, laparoscopic surgery is very hard. This makes it easier to do for a larger percentage of populations. Kind of upfront saying that this is the problem, this is how it helps, as opposed to this can help with some symptomatic relief, which we already have plenty of other treatments for that can do it. So I would question what their problem was. Need for anesthesia, desire for an office-based procedure, maybe, but this hasn't been shown to be done for an office-based procedure. It seems like the solution was to find other uses for this drug-coated balloon, and the innovation, questionable, adding poison, some sort of chemotherapeutic agent. In the studies they look, and the paclitaxel can be found in the ejaculate more than 6 months after the procedure. So it doesn't have, it's not a completely benign office-based procedure the way it is advertised as. So now looking at an open question. So what should we do for bladder neck contractures or vesicoureteral anastomotic stenosis? So the problem is that self-dilation actually has good results, but most patients stop. They don't like it, they have poor quality of life. Endoscopic interventions have poor long-term durability. Open procedures are difficult. This is just to highlight what we've tried. So one is using mitomycin. This is a 2015 paper from the Turns group. It looks at many institutions using many different concentrations of mitomycin, as well as different approaches, hot knife versus cold knife, bringing them all together. They had a 58% success rate. 4 patients with a serious adverse event, 3 needed cystectomy. Kind of keep that in your mind. I'm going to come back to that. So what's the problem? There's actually 2 problems here. One is that endoscopic management is easy, but it has poor durability. And the other problem is an open repair is technically difficult. You can't really see much and opens patients up to not insignificant risks. So how can we solve these problems? So one is they thought about doing robotic surgery for a bladder neck contracture. So this is the robotic YV plasty that Jeffrey talked about last week. You're making a Y incision anteriorly through the scar tissue, advancing a bladder mucosal flap over the top of it. Recently, Dr. Zhao published a meta-analysis of all the papers that have looked at this, and it's not the point of this talk, but basically, patency outcomes are comparable to open surgeries, incontinence rates are better. So we're making we have the same durability as the open procedure. We're making it easier to see, and we might actually be improving continence afterwards. So now the question about what about those non-insignificant risks to the patient? So going for a transperineal approach as a risk for bowel injury, a risk for some sort of vascular injury. So what about a transvesical approach? So with the SP robot, we can now dock directly into the bladder, avoiding that, can go around, can cut out the scar tissue, can do the same bladder mucosal advancement flap. Because I had a friend draw a picture for patients to explain what's happening. But now we're taking a step back. Technically, as somebody I haven't done a bladder neck contracture with the SP transvesically, but has done simple prostatectomies transvesically, you are making the procedure technically more difficult now. So you're kind of increasing the learning curve. So while you are solving one problem, you're adding in another. So maybe not the best solution for it. So it does avoid the intraperitoneal risks of it, but it does require more skill. So the other side of the problem was how do we make the endoscopic procedure more durable? So some people from the Turns group looked at what if we do it multiple times? Is it more durable if we keep putting mitomycin into that scar tissue? And they found that it is more durable for that. It works better for non-radiated patients than radiated patients. And the other thing that they found was those 4 patients that had the catastrophic complications, the 3 that needed cystectomy, it was because those physicians were using a different concentration of mitomycin. So the concentration that Dr. Cavallo uses, that Dr. Bani uses, it's kind of 0.05 per milligrams, hasn't shown to have any of those serious and catastrophic adverse effects. Again, we're trying to figure out and optimize the description, the techniques, the medications for the procedure. This is still very much in the stage 2 part of that innovation. The other option, again, is what Jeffrey talked about last week. So can we do something else instead of preventing scar tissue reformation with preventing fibrosis? Can we do something to cover up that new defect? So this is the transurethral incision mucosal realignment. You can see from the graphic there what we're trying to do, opening up a space using a laparoscopic suturing device, pull a portion of the bladder down over the top of it. So there's less surface area to heal and a decreased risk of any sort of scar reformation. These are the pictures that they published in their the first report of this. They looked at median follow-up of 6 months after 1 procedure, success rate of 89, after 2 procedures, success rate of 100%, no de novo incontinence. So short-term follow-up, but proof of principle is there. So what have we done at Yale? So these are before and after of a patient I've done this on. I can say that I can replicate the results that are published. I've done this procedure 12 times on 11 patients. So far, I've had 2 failures. The first patient I did this on passed away before we got to 1 year follow-up. I haven't had any patient come at exactly 1 year follow-up. You can see their last cystoscopies, one was narrowed, most of them were open. And so we're seeing. So the problem for this is that endoscopic procedures have a poor durability, and there's a problem with the open procedures. There are two avenues for solving these problems. One is to increase the durability of the endoscopic procedures. The other option is to try to improve or decrease the difficulty of the open procedures. For that, we're talking about using adjunctive medications, mitomycin to prevent it, endoscopic suturing, robotic approach, and transvesical approach. This still is very much an open question about which one of these is going to be the best, which one of these is going to be the easiest to teach and proliferate through the rest of the urologic community. So what is surgical innovation? It's basically a new approach to a clinical problem. You're not going to come up with necessarily a new idea, but you can approach it in a different way. Safe innovation requires clear rationale and background for use of the procedure. It can't just be, I have this thing and what can I do with it? You have to have a reason before you try it that it's going to work and why it's going to be different than what is currently there. You need clear definitions of what relevant outcomes are before you start, and then you need honest reporting. Failures are going to be more important than successes because in those failures, you can learn what you can tweak and what we can do better. Don't forget, new toys are not the same as innovation. And sometimes innovation in surgery is actually less surgery. So if you look at our care for necrotizing pancreatitis, it used to be an open surgery. The complications were horrific. Lots of patients died. As they actually looked at the data and saw what we can do, the current treatment for necrotizing pancreatitis, do nothing. Hydrate them, give them antibiotics. So we need to kind of look at the outcomes and follow the data wherever it goes, without any preconceived notions. All right, so in this problem, in this picture, what's the problem? What was that? All right, so we got a giant gorilla. Any other problems? All right, so the gate. So some people see the giant gorilla. That's the problem. That's the disease process. So you can try to figure out how to prevent and augment the disease process. Some people look at this and say the people. Why would people build their city near the giant gorilla? That's your patient. There are some things that we can do and talk to patients about preventing that disease. Some people look at it and say the lock. The lock wasn't strong enough on the gate. And that's trying to improve the surgical processes that we currently have. And other people look at it and say, why is there a door? Why is the door the size of a giant gorilla when the people are the size of the people? And that's where the surgical innovation comes in. Thinking about what can we do to avoid having that door in the wall that allows the giant gorilla to come in. So I'll leave you with one final quote: millions saw the apple fall, but it was only Newton who asked the question why. Always ask the question of why. In surgery, we do the things that we do for a reason. Sometimes that reason is based on historical precedent and things that we didn't know. We have learned new things, and so it's always important to question that dogma and question those precedents.